All right, good afternoon, committee members, and thank you for your service. Senator McClendon, I thank you for sponsoring Bill SB 156. My name is Michael Humber. I'm representing the Alabama Association of Nurse Anesthetists, and I want to tell you the truth about what Senate Bill 156 is about. First of all, the definition change is what is involved in this particular bill. It's a clarification that of what CRNAs do each and every day in our practice. It removes outdated language. The phrase "under the direction of," which is currently in the law, is misleading and improperly used. The word direction is used to intimidate hospital administrators and surgeons into perceived increased liability. Surgeons are not expected to direct a CRNA on how to administer anesthesia. There's been numerous court rulings that have proven that. The phrase "in coordination with" has been inserted in that line. We even defined the word in coordination. Collaboration is already defined in the law, so we are defining coordination because we are not in a collaborative practice. Coordination is defined as the working relationship with a medical doctor, osteopathic physician, podiatric physician, or dentist, each contributing his or her respective expertise in the provision of patient care, and includes the discussion of patient treatment and coordination in the management and delivery of health care. This is not an independent practice bill. This is not a prescriptive authority bill. This is not a strategy by the American Association of Nurse Anesthetists to introduce a new word into law, which you may hear from someone else. This is not a get rid of anesthesiologists bill. This is not an increase in our reimbursement bill. This is simply a clarification of the language that is currently there. There were emails that have been generated that truly do not depict what this bill is about. There's been an email go out that says that this is about full prescriptive power. It is not. It's about the ability to perform an anesthetic procedure for therapeutic and diagnostic therapy. That is not what this bill is about. And it's not about removing the requirement for a physician anesthesiologist. It has nothing in this bill. In closing, I will say this. I would ask that you would ask yourself and all of the next speakers this very brief question. If CRNAs already work in the coordination with a physician, why are they opposed to a bill that defines current practice? I'm willing to take any questions that you might have. Thank you.
Thank you. Greg Everett.
Thank you, Mr. Chairman and members of the committee. My name is Greg Everett. I'm an attorney here in Montgomery. I have been practicing health law for about 37 years now, and I represent a bunch of healthcare trade associations such as the Society of Anesthesiologists. We're here today. Some of you will hear some speakers, as well as other trade associations. But I also represent a lot of healthcare providers. On any given day, my law firm has 25 hospitals that are our clients, and 25 or so physician practices that are our clients. And then we have pharmacists and all sorts of other providers that we also represent. So we're there with them on a day-to-day basis. The other thing that my background is, I worked for y'all for 5 years of that 37 years. I worked for the House and for the Senate reviewing legislation for committees such as yours today. And one of the things that I have learned over many years, that there may be an intent to do something when someone brings a piece of legislation forward, but what you see and what you get may not be what was intended. And I think that's the case today, if in fact the intent as stated. This bill could result in a lot of unintended consequences. I grew up in a little town, Roanoke, Alabama, and there was a saying that I learned very early in life: if it ain't broke, don't fix it. And I think we have that kind of situation today. It's working. And some of the unintended consequences, there's more than changing a definition here. There are multiple changes. They're going to remove, there's a current requirement that a nurse anesthesiologist cannot do what a practitioner nor a specialist can do, and then other changes as well. So it's much more changes involved in this piece of legislation than changing direct oversight to coordination. Thank you, sir.
Thank you. Willie Furr, proponent.
Thank you, Mr. Chairman. Thank you, members of the committee. I'll keep this short and sweet. My name is Willie Furr. I'm a CRNA. I reside in Andalusia, Alabama. I've been there about 15 years. Three things. this bill is not a prescriptive authority bill. It's not a full practice authority bill. When you look at me, I want you to see the faces of the people of Butler County, Crenshaw County, the city of Alp, Alabama, formerly Florala. This is where I live and work. These are where the most impoverished people with the most limited access to health care live. Anybody traveling spring break on the way to the beach, if they have an accident, unfortunately, somebody's got to provide their anesthesia. We provide the only obstetrical services probably within 2 hours. We respond to those emergencies. We save lives. CRNAs are the only ones in these places. If it wasn't for us, there would be no anesthesia service. These people that live in our community are near and dear to my heart. So I would ask you to consider Bill 156.
Thank you. Now, he got it.
So I had one quick question.
Senator Melton, would you like to be recognized?
I would, Mr. Chairman. So how does this bill help you in the current practice that you're doing in Andalusia?
The proposed changes, sir? Yes, sir. When we take a patient to surgery, the physician, we work very well with our surgeons. We have some fabulous, wonderful medical doctors and medical staff in Andalusia, Alabama. When we take them to surgery, our surgeons rely on us to administer the anesthesia. They're focused on doing their job, doing the surgical procedure. So another aspect of that is when we try to increase our services for our communities, we bring in extra specialists, wonderful doctors that we need in our community that provide services we don't currently have. Some of those have never worked in an all CRNA environment. And part of that problem is, and I've had to address this personally 3 times in the last 6 months, meeting after meeting after meeting after meeting, because they are fearful that there is a shared liability. That is a real palpable fear that they have. Even though case law tells us differently, we've had to address that. And it does affect rural hospitals' ability to gain expert surgeons within our community. And we desperately need that.
Okay, thank you, thank you.
Yes, sir.
Well, Mr. Chairman, I'll move on.
Be quick, Senator.
Well, so it helps recruit other specialties, but it doesn't really change your practice at all.
The surgeons rely on us to do the anesthesia. I've never, ever had a surgeon at my facility try to manage the anesthesia that I'm giving. So it will clarify that, yes, sir.
Thank you.
Susie, you are.
I'm Susie Blaylock. I'm the current state president of the Alabama Society of State Anesthesiologists. I'm a practicing anesthesiologist in Muscle Shoals, Alabama. I'd like to just give a personal story. I was an anesthesia nurse. I trained at UAB. I worked at UAB and Caraway Hospital. I did open heart anesthesia under care team management. I went back to anesthesia school because I knew I was practicing at the full scope of my practice, and I knew I was going to be doing anesthesia for the rest of my career. I wanted to do the best and the most that I could do, and so what I knew is that I needed to advance my practice and my scope of practice by deepening my education. I went back to medical school for 4 years, and I went back to anesthesiology residency for 4 years. And it was during that time that light bulb after light bulb went off in my head, and I thought, oh, so this is why I've been doing what I've been doing over the last few years. Oh, now I understand why this doesn't always work in the operating room. Oh, I can see where I could maybe save a life or do better by a deeper understanding of the medical diagnosis and treatment of my patients. You know, I work in a small town. We've worked in a medical care anesthesia direction team, and I'm convinced that having an anesthesiologist immediately available saves lives. I had a patient, a 42-year-old lady. She was a mother of 2. Me and the anesthesia nurse had a plan. We got into the operating room. We knew we were going to have trouble with her airway. We started, and as soon as we started, we lost control of her airway. She did not get oxygen. She started turning blue. We had seconds to act. We managed to, acting as a team, to get enough oxygen in her to save her life while the surgeon made an emergency cut in her throat and put an emergency tracheostomy. That lady's alive today because we took care of her as a team, and I'm convinced that if we did not have medical direction and medical access, she would not be here today.
Okay,
Thank you.
Yes, ma'am. Terry, somebody, C-I-H. Terry, what is your name?
I'm Terry Cahoon.
All right, Terry Cahoon.
Yes.
I want Terry Cahoon and all the subsequent speakers to keep in mind, we're trying to hold this to a minute because we're going to start losing our committee members because of other committees go. Terry Cahoon.
Hey, I'm Terry Cahoon. I'm a nurse anesthesia educator. I've been a CRNA for 25 years and educator for 15 years. My surprise is that anyone would be against this bill. This is not anti-anybody. It's pro-patient. It is pro-specifically rural patients. So our students get to go to 24 different clinical sites within Alabama. We have extremely professional, expert anesthesiologists and CRNAs that help our students be trained. We couldn't do it without both of those members. Again, this is not anti-anybody. This is pro-patient. Thank you.
Thank you. That was a good example to everybody to follow. Dr. Jenny Dollar.
Good afternoon. Thank you for allowing me to be here and speak with you. I am a private practice pediatric anesthesiologist at Children's of Alabama. I'm also the director from Alabama to the board of directors for the American Society of Anesthesiologists. I'm the vice chair for the committee on pediatric anesthesia for the American Society of Anesthesiologists and a past president for the Alabama State Society of Anesthesiologists. I've had the privilege of practicing pediatric anesthesia for over 13 years at our only tertiary care center for pediatric care. Additionally, I'm in my 8th year serving as the service chief of anesthesiology at Children's of Alabama. I'm here because I oppose this bill, and the reason I oppose it is it's unnecessary. Our current laws are strong, what we have works, and there's no reason to change it. I care for some of the most fragile and vulnerable children in our state, from a 1-pound newborn to a severely developmentally disabled child to a previously healthy school-age child who maybe has had an accident. As the chief of anesthesia, I'm responsible for all anesthesia services at my institution: general anesthesia, regional anesthesia, sedation, and analgesia. I'm also responsible for credentialing everybody who provides any type of anesthesia care. I work in the anesthesia care team model, medically directing our institution's capable and experienced nurse anesthetists who I very much value. However, Alabama's children deserve to have me, a physician anesthesiologist, direct their anesthesia care and remain physically and immediately available for every anesthetic.
Thank you.
Thank you.
Ray Dunn.
Thank you for taking the time to hear us out here. I'm going to be very quick. My name's Ray Dunn. I'm a practicing CRNA. I'm also the president of the Alabama Association. I'm a retired naval officer of 26 years where I've served Navy and Marine Corps medicine. I've been in austere environments. I've been in health treatment facilities with the military across the world. I currently practice in Tuscaloosa. I'm the corporate director of anesthesia there and cover part of Fayette too. I ask that you support SB 156 because this is not an independent practice bill. I understand that people are concerned about their practices, that the metropolitan area is going to change. It's not going to change. This wasn't the purpose or the intent of the bill. This is not a prescriptive authority bill. We are not seeking for any other prescriptive privileges outside the operating room that, other than the perioperative period that we currently have. This is clarification. This is clarification of the bill. This is also not a safety issue for the citizens of Alabama. You've heard several compelling stories today. There's not really any evidence in any of these stories that tell you that CRNA practice is unsafe. We currently practice in rural Alabama. We have CRNA-only practices, as you hear and will hear. And I just ask that you consider the fact that we just need declaratory understanding of the language within this in order to be a little bit more clear for those physicians that seek to practice in rural Alabama. Thank you.
Matt Sherritt.
Thank you. I have edited in the interest of time. I'm Matt Scherer. I'm a chairman of anesthesiology at Brookwood Hospital in Birmingham. I do want to say that I have carried out my career thus far in a very respectful way towards CRNAs and anesthesiologists. There are CRNAs and anesthesiologists in this room that I absolutely want and have requested to be involved in the care of my family. It's exactly what I want when I come to the hospital, is the anesthesia care team model. However, in order for that team setting to function at its highest level, trust must be cultivated. For trust to be cultivated, open and honest dialogue must occur. The last time that the Alabama State Society of Anesthesiologists and Alabama Association of Nurse Anesthetists sat together at a table and engaged in a respectful, candid dialogue was roughly 10 years ago. I am told that legislators often want to know, in situations like these, have the two sides tried to work this out on their own? The answer to that question here is an emphatic no. To truly understand the best path forward, more work is needed. The data arguing for one side or other in this vote is suspect at best. Not being able to say whether there are differences in care is far from saying that care is equal. The majority of the non-randomized, non-controlled, non-prospective studies are based largely on mortality data, on death as the ultimate outcome. I would like to propose today that there is a long road between safe and not dead. The citizens of Alabama deserve better than not dead. We as healthcare providers owe it to our patients to strive for excellence, not for not dead. We need to sit together, the ASSA and the ALANA. We need to do so outside of these walls without asking our lawmakers to intervene for us. Until then, overturning what is widely accepted as a safe model, as evidenced by the strong support of the American Society of Anesthesiologists, the American College of Surgeons, the Veterans Administration, and the World Health Organization, to name a few, would be to put the cart far, far before the horse. I therefore leave you with this question. If robust data already existed to support this change, why would the medical community need our elected officials to legislate the change for us? Thank you.
John Yates.
Good afternoon. My name is John Yanes. I serve at...
Just a minute.
I know we're trying to get through, but I don't want us to rush through without losing the essence of what's been said. Most of us, with the exception of one, maybe two, are not medical professionals sitting around this table. I agree wholeheartedly with the last speaker. I believe in bringing both sides together, and you all work things out. However, we do realize that there is a huge void. And Mr. Chairman, I agree with what you said. We are going to see more and more of these types of bills being brought before us, where we are being asked to make the decision. I don't really feel qualified to make those types of decisions. I do believe that in the medical profession, and I look at myself as a patient. When I go to whatever profession, I expect to get the best quality help and care from the person that is best qualified to provide it. However, everybody has a role to play, and we depend upon each other. And so, in areas where we have those voids, we have got to find a balance, Mr. Chairman, in particular in the rural areas, to address this. Sometimes I kind of feel that some of these legislatures being brought before us, because I remember one that I very ardently fought for, which was the midwifery deal, looking at the same void. And the fact of the matter is, somebody said, well, they don't really practice in the rural areas, they go out and expand into other areas. And it becomes a competition between the anesthetists or the midwifery people and the obstetrics or whatever. But if you come together, because you do rely on each other, I do believe that you can probably bring something, working with the chair, that we can all agree on, and maybe you all can agree on. But the bottom line is that to better serve the citizens of this state. So I'm hoping, out of all of this, Mr. Chairman, that we don't rush through it, because if we can get it right and get a balance, we probably can work out the rest of them.
Thank you for your comments. We can talk. This is going to be our last speaker, because we hardly have a skeleton crew up here now. Okay, let's go.
My name is John Yanes. I serve as CEO of Anesthesia Health. I've served as CEO for 4 years. Anesthesia Health is one of 89 hospitals within LifePoint Health. We serve in 30 states. 4 of those hospitals are here in Alabama. So we have the opportunity of seeing various models work throughout our system. If you want to see a model that works, an anesthesia CRNA model that works, I invite you to our facility. I have been serving for 4 years. Prior to my arrival, the previous CEO decided to bring in an anesthesiologist to lead anesthesia service at our facility, that did not work too well. So I picked up the pieces. I worked with our surgeons. Our surgeons actually approached me about bringing back the model that we had before, which is indeed what we've done. I agree with you that we need to work together, and as hospitals are challenged to continue to serve, particularly in rural communities, we have to ask ourselves these questions. How do we work together to develop viable solutions to continue to serve our communities? How do we work together to expand the pool of reliable quality health resources for the people we serve, particularly in smaller communities? The CRNAs are members of our medical staff at our hospital. They are allied health professionals. They undergo the same scrutiny and credentialing and privileging process as our physicians do.
We need to get there.
The CRNAs are highly trained practitioners who practice to the full extent of the education and training. And again, the door is open, and I invite you to our facility. Thank you.
And out of fairness, we've had 5 on one side and 4 on the other, so we're gonna wrap it up with Dr. Kurt Sin. You're the caboose.
Yes, thank you. I'm Kurt Sin. I'm an anesthesiologist, physician practicing in Birmingham for the last 20 years. And my colleague, Dr. Scherer, mentioned the World Health Organization, and that is a body that directs international health. It was established over 70 years ago. And just last year, this body established their standards for safe practice of anesthesia. These standards apply across every country in the world. And within the description of their standards, the following is included. Anesthesia is inherently complex and potentially very hazardous, and its safe provision requires a high level of expertise in medical diagnosis, pharmacology, physiology, and anatomy, as well as considerable practical skill. Therefore, anesthesiology is viewed as a medical practice. It goes on, and I wish I had more time, but I think the current law we have protects our citizens when they undergo anesthesia. If there isn't an anesthesiologist in this rural setting, there is a physician or a dentist in the case of a dental procedure that is overseeing things from a medical perspective. We do not need to change this, and I urge you to vote no.